All right, we're live and recording. Tell me what would you like to discuss today?
Hi, Dr. Bhatti. Yes, so today I wanted to talk about some of the common spinal cord pathologies and maybe some key defining features of each one, how to tell them apart. So in particular, I was thinking about an epidural abscess, transverse myelitis, and normal cord compression.
All right, very good. And I think when we were talking earlier, you were mentioning that there are some common features of a lesion of spinal cord that kind of overlaps or is common between any cause of involvement of spinal cord. Do you mind pointing out a few of those, and then I can add? And let's just talk about, okay, what is a spinal cord lesion presentation in general, regardless of the cause?
Sure. So basically, from my understanding, typically below the level of a lesion, you'll have upper motor neuron signs. So things like hyperreflexia. You can have some extensor plantar responses. You also typically have weakness below the level of the lesion. You can have some sensory dysfunction. Whereas at the level or above, you might have some lower motor neuron signs or atrophy, things of that nature. But as you just mentioned, these are common between all the spinal cord injuries. So, what are some other features that may help you distinguish between them?
Yeah, and let me just quickly share my screen and point out that, one of the key features when we are thinking about spinal cord lesions is to remember this anatomy, that there are pathways that are lined up between different parts of the spinal cord. So in the center is the H-shaped gray matter, and this is the lower motor neuron that is supplying at that segment. And then you have the dorsal column and you have the anterolateral spinal column. And then you have the corticospinal pathways or fibers. So dorsal pyramidal tract and then the lateral pyramidal tract that is coming down. And the arrangement of it and when they cross from one side to the other creates a lot of variation between, how that lesion will present at the level and below the level. And, this is the pathways we're talking about, just to get a sense. So I just want, all of you to remember that, these are common concepts between what a spinal cord lesion will present like. And then another common concept to remember with spinal cord lesion in general, which is true of all of it, is that you have what is called a spinal shock. And spinal shock is that if any acute sudden lesion of spinal cord will not present in a way that, that's the standard textbook way of spinal cord lesion. So for example, we talked about in spinal cord lesion that below the level, you will have hyperreflexia for motor neuron features and spasticity. In acute spinal shock, when the lesions occurs, there is complete flaccid paralysis. Now, flaccid paralysis or weakness, you think of it as a lower motor feature. So like a nerve transection or a brachial plexus injury or plexus injury or a muscle injury. But in acute spinal shock, you do not have the classic spinal cord presentation. So you do not want to forget that. And that acute spinal shock can last from minutes to days. So up to 2 days of spinal shock can happen, but usually it's hours. So anywhere from 1 to 6 hours is typical spinal shock. So that in very early evaluation of the patient in spinal shock, you will not see hyperreflexia, you will not see Babinski sign, you will not see spasticity or increased motor tone. You will see opposite, loss of reflexes, complete flaccid tone, and mute Babinski or no response to Babinski reflex. So that sometimes confuses people. And remember that's a spinal shock phenomena that lasts for a few hours and is gone, and then the classic picture sets in. So that's one. Now I think you highlighted 3 of the common ways where a spinal cord can be damaged. The 4th one I will add will be a spinal infarct or stroke of the spinal cord, which is not that common, but it kind of fits with the other 3. So I'll just put it in there. Now let's talk about the 3 of them. There are many ways to look at 3 of them. The one way of looking at them will be the acuteness, how quickly or fast something sets in. Now, the spinal cord compression typically sets in very acutely. So what do we mean by spinal cord compression? Is that something from our side is pressing in and pushing on the spinal cord. So if I just simply Google the pictures and share it, and so none of this is copyrighted, so you can all Google it and find similar pictures. So I'm not making anything special, but there is something on the outside. Let's look at this picture here. This gray mirrors the spinal cord, and the dark black around is the CSF in this kind of sequence of MRI. And as you go down, you will see there's space around the spinal cord, and then it suddenly disappears, and there's something that is pushing in. So if you follow the normal line of the posterior surface of vertebral bodies, there is something coming in suddenly, and that is pushing and compressing on that spinal cord. So this is a cord compression. Now, compression classically means there is something from outside pushing it. Now, this could be outside the dura or could be within the dura. It could be a tumor. It could be blood clot. It could be pus. It could be the disc herniating from it, or it could be fat, and it could be even iatrogenic. It could be a bullet sharpener or fragment or something like that. The most common, of course, are disc herniations. The disc, something like this, will protrude out and look like this. And the most worrisome is bleed. So the fastest of all of the list of things that I mentioned, besides the bullet injury, will be, and bullet itself may not be the problem, but the fragments of the bone broken by the bullet might cause kind of a compression, but usually also not just compression, but also contusion or bruise of the spinal cord. So the fastest of them is the blood, and the history is very simple. The young athlete playing had a minor trauma. He was playing football and got hit, bumped into the head, fell down, complained of some back pain, but now bothersome, started playing, was fine for a few hours, and then suddenly collapsed, and now he cannot move his legs. So that kind of an acute presentation means that something just happened in the last few hours or minutes, and that's typically classically the blood. And you don't want to miss it, because if you do, you can easily extract it. If you don't, then the patient may be paralyzed for the rest of the life. The other compressions are usually more slow. They can come on in days, sometimes weeks, but most of the time it's acute to subacute, hours to days. Now, in contrast to that will be something like an epidural abscess or Pott's disease or infection in or around the spinal cord. And that does in the long run leads to infection, but it can also cause a direct infection like a myelitis. So it usually is a mixed picture of myelitis or infection of the spinal cord and compression, but it's very slow. It can take weeks to months to come on, and often have features of infection. So that you would expect from a pus, like fevers and night sweats and chills and rigors, and just malaise and fatigue that has been going on for weeks or months, and spot tenderness, that the area that's infected, if you press on it, or they will say that there is a spot that hurts, and that spot tenderness is also very classic for an infection source. And that leaves us to the last one, which is the transverse myelitis, which is anything that causes inflammation inside the spinal cord. Now, it is such a broad category that it includes everything. So if we go back to Dr. Google and look at what a transverse myelitis might look like. So if you look at, let's see, this picture over here, you will see that the normal gray of the brain is visible in the cerebellum here, in the spinal cord here, has some whitish feature inside it. This white color in the MRI classically means edema or water, restricted water. So normally there's water everywhere, but this is water which is inside the swollen cells and is trapped inside the cell and cannot diffuse. And that trapped water in MRI creates a white color on most sequences. And that white color means there's trapped water, there's swelling of the cells. These cells are not functional. They're not able to move this water, let the water diffuse easily in and out. And that is what is a myelitis. Now, we call it transverse myelitis because if you look at an axial slice here, it is involving a transverse segment of the spinal cord. But it's a very weak word to use because usually the myelitis is longitudinal, meaning that it runs from one level to below. It may be continuous, it may be broken into different fragments. It may be patchy, it may be very clear margin. It may not have a clear margin, all of that. So if we just look at transverse myelitis examples here. And let's see some of them. So some may look more distinct, some are than others. So this one also has swelling with it. So you can see the spinal cord looks swollen. So if you compare up here to down here, and then down here again, you see the center is swollen, but it's more diffuse and more broad involvement of the spinal cord. Almost the whole spinal cord is involved, in contrast to this one here, where there is milder swelling, much smaller segment, much less involvement. And here's another example where again, there is a segment and then there is not that much of a swelling. The cord looks slightly swollen, but not too bad. And this is the axial section. And this gray is normal. This kind of a half arc is normal. And all of this white around that gray is abnormal. That's the swollen, that's the edema that is causing the transverse myelitis. So what can cause transverse myelitis? Normally, when we say transverse myelitis, we mean autoimmune, immune process, but there is infectious transverse myelitis, there is rheumatological transverse myelitis. So even epidural abscess can also have transverse myelitis and often does. And that's why I said it has a mixed picture of compression and inflammation of the spinal cord. So if there's a epidural bleed or compression, usually the presentation acute, subacute. If it's an infection, it's slow, it's with fever, rigors, chills. If it's transverse myelitis, it's acute to subacute, again, usually days or weeks, and slowly. One thing about transverse myelitis is that in compared to the epidural compression myelopathy, it is usually slowly progressive. So it keeps on getting worse. It is also multi-level. So disc herniation or bleed is usually at one level, while the transverse myelitis usually, as we were seeing, involves 3, 4, 5 different vertebral heights or multiple different areas. So it involves more places, and that's why it looks different. Does this make sense? Anything that I didn't cover or still in your mind as a question?
No, I think that was very helpful. So yeah, obviously they could present similarly, but different ways, as you mentioned, to tell them apart are, onset of symptoms in terms of the duration, how long, how quick, associated symptoms in terms of like fever, chills, general malaise, and then obviously imaging can help. So those sort of, 3 different areas are ways to distinguish these 3 different pathologies, which, yeah, I think that was very helpful. Thank you.
Awesome.